Welcome to the Low Carb Conferences podcast. I'm your host, Dr. Jeff Gerber. And today our special guest is Dr. Marc Cucuzzella, and he'll be speaking at our conference in February. Marc is also one of our triple threat presenters as he's passionate about fitness, nutrition, and science. He's been a big supporter of our conference over the years. So how's it going today, Marc?
Oh, it's going well. It's 70 degrees here in West Virginia. I think this is like the last, warm fall week, and then winter will probably hit. I hear you guys got snow already out there, or at least up in the mountains.
Up in the mountains, yeah, it was beautiful here for Halloween last night.
Yeah, maybe it's been a couple poor ski seasons with whether it's just global warming and such, but maybe this year you guys will get some good skiing in.
Well, we always keep our fingers crossed. So a little bit more about Marc. Marc's a retired Air Force Reserve Lieutenant Colonel, a family doctor who actively sees patients, and also is a professor at West Virginia University School of Medicine. Marc conducts medical education courses on health, fitness, and running, and developed the U.S. Air Force Efficient Running Program. Marc has been an advocate for low-carb nutritional science and has published several papers, as well as lobbying to update nutritional guidelines. Marc has received several distinguished awards for his contributions to teaching, fitness, and community. Marc is truly an exceptional educator. So, Marc, if you can provide some more background and tell us about your personal and professional interests.
Well, thank you for the kind words. I'm just part of the tribe, Jeff, and I think I came to your first conference in Breckenridge. I don't know what year, maybe 2017, 16. It goes way back. And I think it was just so cool to see, a lot of people all over the globe doing similar things, people that are doing a little bit of science, and everyone's got a little higher weight in their own area. I'm probably more clinical and, dabble in a little bit of the science because it's so fascinating. And then there's the real scientists in the room, who are doing the bench research, people like, David Ludwig types, published hundreds of papers. I've published maybe half a dozen on this topic. But I just see that the power. I live in West Virginia, Jeff, which is the most obese and diabetic state in the country. I mean, we're probably 1 and 2 with Mississippi, depending on which random poll you read. So there's a huge need, and gosh, for over 10 years we've been doing diabetes remission in my community, and it's been very much community driven. My institution allows me to do this, but it certainly hasn't been embraced as a standard of care, in around my state. But there's pockets now, based on some of the work we're doing here, and it's spreading. We can make type 2 diabetes go away. A little how I got into this. I think all of us have some kind of backwards way in based on our own story. So you mentioned the efficient running program. So my personal background is I've been a competitive runner and athlete for many years, going back into college days. And in the Air Force, I was traveling around a lot, running races and doing a lot of sports med. And there's a fitness test in the Air Force, and it involves running. So imagine if you went into your hospital, Jeff, and you had to pass a 1.5 mile run test. If you just walked in, how many people would not pass that test? And then you have to go home, right? You lose your job. So in about 2012, they had changed the standards of this fitness test. It was a bicycle test or a step test. It had various different parameters, but then a new chief of staff came in and said, we're going to make this easy for everybody. We're going to make it a run test. And if you fail the run test, you fail, and you can get some remediation. But if you don't pass, you're discharged. And that's a pretty big deal if that's you in your career. And the failure rates went up to close to about 25%, which is profound, right? That's like going into your hospital and the next day, a quarter of your work staff, might not be able to continue their career. So they gave me 6 months to work on this project. And I noticed immediately just by digging in, I'd never been a data person because you never have time. You read some opinion papers, people need to run more, exercise more. That's the only way to get fit. I mean, that's what I kind of believed. But then I looked at data, and it was pretty clear that obesity was driving fitness test failures. And I think now, 10 years later, probably not too surprising. I didn't understand the metabolic component to that. I just figured, well, gosh, yeah, if you're carrying an extra 40 pounds, it's harder to run. And I kind of went down the rabbit hole of nutrition. And, the internet was kind of new there, and you could actually Google search in 2012. You're just randomly searching stuff. And this article came up from Gary Taubes, in the New York Times. Maybe it's all been a big fat lie, and it's just, I read that and I was like, well, that's fascinating, right? Because, in my career, maybe we're about the same age, I think, Jeff. I graduated residency in 95. When did you finish residency?
I'm afraid to tell you it was 80
Oh, wow.
82. Yeah,
So you're
86.
giving away
Actually,
your
yeah.
secret sauce there.
86 is, yeah.
Yeah. So you look young, you look well, Jeff. So, I just turned 56, but yeah, so this was like really different than everything I had learned. But he had also, that article was kind of following a book that he had published called Good Calories, Bad Calories, probably one of the earlier books you had read, Jeff, back in I think that was published in 2007, maybe. So it was like a 450-page tome, with like 1,000 references. So I read that book like twice, and you start scratching your head. You're like, gosh, maybe he's right, right? Maybe Gary Taubes is right. And I spent 6 months, and a good part of that time was traveling to multiple military bases around the world. And you'd be in a base gym, Jeff, and imagine like all the people who needed remediation is sitting in the base gym, and they don't want to be there, right? They're the ones who failed the fitness test. And here, like, the running doctor is going to come talk to them and like yell at them and tell them to run more. That's what they were thinking. But we started off like this: has anyone in the room lost 50 pounds and kept it off for a year? It just kind of make light, just start a different conversation. And there's always be like one hand, maybe a couple, go up and say, Sergeant Smith, what did you do? And across the board, no matter where you were in the world and who that person was, it was some variant of the same. They'd say, well, I got rid of all the bread, right? Or I did paleo, which in those days, there wasn't paleo junk food. It was like, eat meat and cheese and some vegetables. Or like a gutsy one would actually, they knew I was a doctor and they were afraid maybe, I would throw them out of the room. They'd say like, well, I did this thing called Atkins, and they were like but I was like, yeah, and then someone else would say the same thing. I got rid of soda. So, okay, that's like, we call it observational evidence, right? So you see something that's real, and then you got to explain it. So that was enough for me to say, okay, maybe, because there wasn't a lot of randomized trials then. Eric Westman's work hadn't been published yet. Finney and Valek's work hasn't, but so that, based on scientific principles, history, and observational evidence, I knew there must be something to this. And kind of just serendipitously, kind of roads collide at the same time. I got to go get my physical every year in the military to maintain standards and be deployable. So my A1C was up in the pre-diabetes range. It was like 6.3 range. And I look like this. I just actually won the Air Force Marathon. So I'm like this skinny running doc. And, but at that time, it was really weird. I was waking up at 2 a.m. every morning, needing to eat more and more. I was like eating just crazy amounts. And so they sent me over to the endocrine clinic, and they did what's called a C-peptide, which is a marker for those listening who may not know labs. That's a marker of your own insulin production. We call it endogenous. So this is the insulin that my pancreas is producing. So that's an extremely low number. And then they put on like a CGM, which was kind of new at the time. You couldn't see it on your phone. None of us had phones. It was just like a box you wore for 3 days, and they would track your sugar and then download that data. And my data was like all over the place. I'd spike up to like 250, but then I would crash because I was really insulin sensitive, had a little bit of a second phase insulin response, but like no first phase insulin response. So sugar, that would explain my 2 a.m. awakenings, because I was always like hungry, right? Like at 10 at night, I'm hungry. I'd eat more cereal, and be crashing to like glucose of 50 at 2 a.m, wake up. And that was like, I was the guy, Jeff, that would be, the drug reps would always bring bagels to the hospital, right? So I would be the guy, even though I didn't like the drug reps, but I was always hungry. So I would always be like hoarding a bagel or two just to stick in my pouch. So like within a week after, because at that time, what was fortunate, Jeff, was I'd read all the Taubes stuff. So I wasn't afraid. If I hadn't come across Gary Taubes and Good Calories, Bad Calories, I probably would have said, well, the solution's not to eat sugar, but if I eat fat, it's going to cause me a heart attack. My dad had a heart attack and bypass at age 35. So I felt eminently confident to flip the food pyramid upside down. And that changed my life. All of a sudden, it's like, I feel good. I'm not hungry all the time. I have energy again. It was personally, that just was epiphanal in just how I felt.
Well, let
and then
me,
started applying this to patients, and that's, the story goes on from there. But yeah.
I want to hear about patients. I just have to back up a little bit. Actually, I graduated from residency in '86, and I'm sorry, medical school in '86, and then residency was '90. So I'm a few years ahead of
Yeah,
you.
a couple years off, but yeah,
But
same gen.
yeah, but my interest began in around the year 2000, Y2K, about 10 years before Gary Taubes hit the
Mm.
road. And it was Dr. Atkins that I was influenced by. And then when Gary Taubes came along, I said, well, who's this guy? He's just recreating what Dr. Atkins was talking about, but in a very good way. And then Nina Teicholz followed as well. And so yeah, just excellent. And I had some of my own metabolic health issues back at the time, and I had learned from my patients as well. And it's just interesting your story as an ultra endurance athlete. It sounds similar to the story of Tim Noakes in South Africa, where he also discovered that he was a pre-diabetic. And I imagine you were performing at peak levels and pounding down carbs.
Oh yeah, I was a pure glucose burner, but I could burn glucose like the best of them, so, but you're constantly chasing it. I think at that time it hadn't negatively impacted my running performance. I was doing more shorter events, not super long ultra marathons where you really have to be fat adapted. And I thought that was just the way it was, right? There was no other alternative, right? You carbo load, you eat a lot of carbs during the event, right? A lot of goos and gels and Gatorades and sports drinks, and replenish your carbs, and, wake up, rinse, repeat. But when I made the switch for my own personal health, I certainly didn't make that switch out of thinking it was going to make me run better. I knew nothing about the running side of low carbohydrate. Most of that hadn't even been talked about. But, I could wake up in the morning and I felt great without, I used to always have to eat before I ran, but I could wake up in the morning and go run for like 2 hours and feel great. And actually feel better, like in the second hour with, taking some fluids and maybe some salt, if it's hot. But that was just really kind of liberating, that you don't need to be constantly chugging sugar. And Phil Maffetone was a big influence on my world at the time. So he's like the shaman of endurance sports, and he was talking about fat adaptation in like 1980s with the world-class triathletes of the day. So I went back, and he's a good friend, and we've spoken and taught together, but went back and read a lot of Phil's work. And it's like, oh my gosh, yeah, you slow down too by slowing down your pace, being a conversational pace. You teach your body to use fat as fuel, and your speed gets quicker at that conversational pace. It doesn't happen overnight. This is probably like a 6-month process before you really got your body tuned to being able to run without calories, to be able to make that energy yourself. So if you're listening to this and think it's a one day, turn the food pyramid upside down, go for a 2-hour run without carbohydrates, you're kidding yourself. But I mean, I hope that you and I both have a long life of physical activity, whether it's skiing, walking, running, cycling, or whatever it is you like to do, that's being able to do that with your own stored energy is the most anti-inflammatory path.
Yeah. So, I'm sure that, and as you've told your story, your metabolic health improved, but you were already an elite athlete before you had switched over to using predominantly fuel. But I do recall that you'd shared with others that your VO2 max and your aerobic threshold, and it's a bit technical, maybe you can get into that, went through the roof when you switched to fat as a primary fuel.
Yeah, so it's not the max. So there's a couple things make this easy for people to understand. So the VO2 max is kind of the maximum output your engine can do. And when you're running or cycling at your VO2 max, you're pretty much 100% glucose burning, right? You're just lighting matches. That's that top end gear. You might have gear 1, 2, 3, 4, 5. That's where you've kind of gone through the gears and you're at gear 5 until you fall off the back of the treadmill. So that max value is a marker of your fitness. But what's most important is what percent of that max can you exercise at while you're still burning fat. So it's kind of like you've got a Prius car. You've got this little gas tank and an electric battery. and that electric battery is highly efficient, and can go for a long time. So if you can be at like 90% of your VO2 max still electric, meaning burning fat, you don't bonk. And I think everyone's probably heard that term, right? And in a marathon, you're going to somehow hit the wall, like you run out of glycogen. But if your body can oxidize fat at rapid rates, you can be running at very high speeds, close to your maximum effort, and still be burning fat. And that's a very good place to be, because then you don't need to eat calories, right? You're good. Like a lot of people doing these triathlons, running events, they say, well, my stomach goes, because they're trying to, well, I need 400 calories an hour because I'm running this pace, because they can't burn fat for fuel. But when you're running, it's very hard to digest 400 calories an hour. Imagine, pounding, 4 gels an hour, over several hours, and ultimately your stomach just shuts down. So the less you have to rely on that, and the more you can use your own fat for fuel, that's a good place to be. And that level on in my own numbers, going and getting these tests, went from, I used to switch over at about 50% of my max to burning carbs, like switch into the gas tank. But after, several, maybe 4 or 5 years of low carb and slowing down, it's the right type of training, I could be running at about 90% of my VO2 max, still burning fat and oxidizing fat at about 1.8 to 2 grams per minute. And before they started studying low carbohydrate athletes, the highest they were recording in runners and cyclists was about 1 gram of fat a minute, because they were more reliant on carbs. So there's this whole other world of people doing low carb that hadn't been studied yet. And Finney and Volek have studied that group in a study called the FASTER trial, where a group, and this isn't these people have been on low carb ways of eating for about 18 months. So it wasn't like someone like 3 weeks. You'll see things in the literature, Jeff, well, if you switch your diet in 3 weeks, you actually do worse. And I was like, well, that's probably true, because it takes more than 3 weeks to really change the way your body accesses fuel. So I hope that makes some basic sense. But your goal is to up your fat oxidation, and that's human health and performance.
So yeah, I believe that you're basically described aerobic threshold, and your numbers were very remarkable because they hadn't studied fat adapted athletes. And the point is that the way the measurement works is you really need oxygen to metabolize fat. And you can, in an aerobic way, and
Yeah.
anaerobically, you can process carbohydrate. So look, obviously there's a role for carbohydrate in diet and lifestyle.
Yeah, absolutely.
But the
Even
point is
running.
that as time goes on, being an athlete dependent on carbohydrates isn't necessarily a healthy thing.
Yeah, I think you have to look at who, if you or I are seeing a patient, who is the patient? If you're a 20-year-old world-class Kenyan runner, you can light matches, you can burn carbs. They don't have metabolic syndrome. They don't have an inflammatory response to their carbohydrates. They don't have atherosclerosis. Eat carbs, run fast until they probably get to a certain age. But actually, when you look at that group, though, they can burn carbs super fast, super efficient, but they're also actually, their zone 2 training shows that they're actually very good fat burners too. So they call it fat max. So at what speed are you burning the most fat for you as an individual? So even these people that are eating mostly predominantly carbohydrate, they're so fit just by their training, they can burn a lot of fat. And I think that's something that gets missed in the low carb world, is that no, these people eating carbs are actually like really fit. They don't burn fat as efficiently as a low carb athlete, but they're burning way more fat than a diabetic patient who is actually on a low carb diet, because they're so metabolically broken. These people need a very slow rehab out, because they get off the couch and their bodies, just their mitochondria don't work well. They produce lactate at the most minimal level of exertion. And when lactate's up, you can't use fat for fuel. That's why most of our diabetes patients, they go get the mail. They don't feel good. They're in an energy crisis. And that's where, clinicians listening to this, they need our help, because we need those people to slow down, right? If they go to the gym and they're told to do high intensity, they can't do that. like they're broken. They need to kind of start in gear one, and maybe in 6 months, when they've actually built those mitochondria again, in the correct way, got their glucoses down, then they can start to ramp up the exercise intensity. It's very individualized. The role for carbohydrates. So if you're mostly a low carb person, very well fat adapted, while you're exercising, so say you're listening to this and you want to go do like people are doing these ultra marathons now, like a 50-mile race. They may be out there 8 to 10 to 12 hours, and you want to stabilize your blood glucose. When you're exercising, your body disposes of the glucose without insulin, and it does not shut down your fat burning. So if you're taking in, 100, 150 calories of some form of glucose and electrolyte while you're exercising, once you've made the adaptation to burning fat, that's money in the bank, because that's good, right? You're not raising insulin, because the insulin shuts off fat burning. But while you're exercising, your body, they're called GLUT4 pathways for the geeky people in the room. But yeah, so these GLUT4 pathways come to the surface of the cell and allow the glucose to come in without insulin. So you're not spiking insulin, by taking a little hit of, some type of sports drink. We're not talking about drinking 32 ounces, but it's kind of the drip method. You just keep a little glucose going, because if your brain gets hypoglycemic, it tells you stop, because your brain is like captain of the ship. So if any of you all have exercised and you get a little hypoglycemia, or like you feel like you just want to stop, you haven't bonked. You got plenty of energy. Just give yourself a little hit of glucose. Don't be, some low carbers are afraid to touch any carbohydrates. No, your body's disposing of that. I'm not telling you to do that while you're not exercising, but while you're exercising, your body has like a backdoor disposal system of that little bit of glucose to just help you that day, if your goal is, to have performance that day.
Yeah. So basically you're saying exercise is a great way to shunt energy into muscle.
Yes.
Through GLUT4 pathways and others.
It escalates like 10 to 50. People have even said 100 times that your muscles are the biggest sink of blood glucose. And exercise is basically, it's like a vacuum of glucose. So we did a study with these CGMs, Jeff, put them on new diabetes patients, didn't give them a lot of coaching, had them just log their foods a little bit, learn from it. CGM, continuous glucose monitor. They're new diabetes patients. And we also wanted them to see the effect of exercise, right? Go for a walk, see what happens. And across the board, going for a walk was like, taking a little short-acting insulin. And it was cool. So they learned that. Like oh, wow, like my sugar's 180, I go for a walk, 30 minutes, not 5 minutes, like a nice stroll, like not even hard, right? Just go walk the dog 30 minutes. And the glucose, and I think that's something as clinicians, we really should be reinforcing with patients, because exercise is probably the biggest lever for, I know you and Ivor talk about the levers, right? So for longevity, quality of life, exercise, like you just get off the couch and your 10-year all-cause mortality goes down like 50%. It's crazy. Nothing else we do has that much impact. Combine it with better eating, and it's kind of the it's duplicative, but the exercise is like super powerful.
So yes, and we encourage people to do anything and everything that they really enjoy: movement, activity, exercise, cardio, and resistance. And you kind of live on the endurance side of it. And at our conference next year, we're going to have a bunch of speakers that are actually on the resistance side of it. And so
it's all good. Behind me, I have a set of kettlebells and resistance bands. I'm getting old, so like I love to run for my brain, but I come back and I'm lifting my kettlebells. So I think either they're not either or. I think you need to do, you and we're becoming old guys, right? We have to do strength training to keep our muscle mass.
So I think it's fair to say we all have our addictions, and
we're addicted to the endurance.
Addicted to the endurance part of it, but I'm also glad to hear that you do the resistance.
Oh, you have to. It's non-negotiable, or else you get sarcopenia. And like the protein and the resistance is to keep the muscles, and the endurance is for happiness. For at least for me, that's for my mood.
That's absolutely. I mean, any type of exercise is good. But I have to ask the endurance guru, and again, to me, you're a model specimen for someone that can endure. And the question is, are there potential long-term risks to prolonged endurance?
Yeah, that's always been a big debate. So if you look at, they're called, the curves, right? So some people call it this inverse U curve. So we know that that first 30 minutes a day, your mortality, all-cause mortality drops, significantly. And then you get out to like an hour and a half a day and things tend to flatten. Now you'll see a couple small studies showing that if you're really hammering your body several hours a day, like world-class triathlete level training, there might be a little uptick, and that's mostly right heart strain and atrial fibrillation. But in my clinic, I've yet to meet a patient exercising 8 hours a day. So maybe if you're a coach of these people that are just doing, and that's not healthy exercise, they're trying to win prize money. But for you and I and anyone working in a clinic, it's like that it's all good. Like the fitter you are, the longer you live, right? So there's not consistency in this inverse U where there's going to be this detrimental effect of too much exercise. Most of the literature actually does not support that. The more you do, the better off you are. But again, that's, if you don't get agreement in the data, then you have to say, well, maybe it's not absolutely true, right? So there's complete agreement that getting off the couch is very good for you. Running 8 hours a day, maybe not. And I don't encourage anyone to do that. But that middle of the road exercise and early exercise, getting off the couch, probably the biggest lever anyone can do for their health.
Sure. Well, I've had my fair share of orthopedic injuries from all my sports over my lifetime. And of late, I've cut back on running and I'm doing some more resistance training. The other interesting finding is that they see higher calcium scores in endurance athletes. And the question is that nature or nurture? And, maybe it's got to do with diet, who knows, but that's just an interesting observation.
Yeah. And I'm glad you brought that up because it was a different talk. I actually pulled up some really interesting stuff on that, Jeff. And one is like, you could even Google autopsy Clarence DeMar. So Clarence DeMar was born in 1880 something, and he won like 7 Boston marathons. And Paul Dudley White of Eisenhower fame, he was Eisenhower's cardiologist, probably told him to not eat cholesterol. But when they actually did his autopsy, he had significant calcium, as do several endurance athletes. But the calcium density is higher, but the diameter of the blood vessels, like Clarence DeMar, the diameter of his blood vessels were like twice, like his pipes are huge and he's got some dense calcification. So when you look at event rates, runners have less cardiac event rates than people that don't. But I think, again, it becomes the individual patient. I do a lot of calcium scores. If I see a runner who has a high calcium score, I want to know what their lipids are. I want to know if they have metabolic syndrome. Like, do they have something that's going to contribute to instability of that plaque? Aspirin, possibly if they've got a high genetic predisposition for ApoB or Lp(a), that's the role of medical therapy, in these folks, because they do have a high plaque burden. And we don't really have good science to know which exact plaques are unstable or stable. There's actually an article, it's called The Myth of the Vulnerable Plaque, if anyone wants to pull that one up. It's a fascinating article because the cardiologists tend to always be able to tell their patients, this is a vulnerable plaque, we're going to put a stent in. Maybe it makes them feel good, the patient good, and it's good for business, but we have no clue really what the vulnerable plaque is. I mean, do you have any insight, Jeff, on like when you see all these calcium scores, just by seeing thousands of them, do you have any insight into which distributions might be more vulnerable?
So it's evolving, Mark. And Karam Nasir, cardiologist, will be speaking on the greatest in cardiovascular imaging.
Oh yeah, it's very evolving.
Yeah, now they're using AI technology to interpret CT angiograms. So the word's still out. So it's a fascinating area to look at. And Yeah, I think what we can do, you did mention, your talk is related to zone two training, and that seems to be appropriate as we age, as time goes on, and especially you mentioned patients that have weight issues and need to kind of gently go back into things. But that really brings me into the clinical setting of, which we're both doctors still seeing patients. We're both family doctors,
Yeah.
right? And, I'm in a family practice and you are in, it's a diabetes
Mix.
center.
I do a mix of just general primary care family practice, some diabetes specialty, and I do all the cardiovascular testing. So this, we really get into the weeds of digging through the chart. Even these lung CT screenings now, you're picking up big plaque burden, and the patients have no idea. No one's ever talked to them. Incidental coronary calcium on all these different studies. Most patients walking in for a stress test, because we image everybody now in an ER. They've had CT angiograms for PEs, but I'd say 50% already have known cardiovascular disease by a test already done, and the patient doesn't know it yet. And it's not quantified in most cases either, but you'll see these comments on these other studies people have. But yeah, it's bringing all this together is what you and I do to try to help people not die of cardiovascular disease. That's the big risk for the diabetics.
When we see scans like incidental findings of coronary calcium, we send them for the heart calcium score, and we really want to quantitate, find out if patient has cardiac symptoms. And I do just want to mention there's, Matt Budoff, who's one of the cardiologists that's done a lot of research around heart imaging. He coined the term stable calcium. So like your athlete that
some of the runners,
runners that have stable calcium and the pipes are still flowing and they've never had an event. And so in a sense, that's somewhat reassuring that they haven't had events despite having these higher calcium scores. So in the clinic before the podcast, we were mentioning the use of CGMs, and I imagine our approach to addressing health, weight, diabetes, prediabetes in the clinic is similar.
Yeah, I've read your book. I mean, it's very similar, figure out which lever, stress, sleep, they don't move, right? But I think nutrition is the biggest lever to immediately fix someone's blood glucose, is get rid of glucose in the diet. But I think if they don't address the other things, it has an expiration date. As you see, like if they don't fix their other issues, they'll rebound. So start them off. And the CGMs are great, Jeff, as you know too. Like they see it immediately. Gosh, they go like a week with green list foods, which are going to be, plants and animals, non-starchy veg, and they see their glucoses be like 250, 300, and without medications even, they're like normal in a week. So it gives them hope. All right, now let's talk about, the sustainability of what you're doing and what other levers. You need to build some trust with them first. A lot of these people, they're very skeptical of healthcare, because every time they come in, it's a different doctor, right? They're on a new medication, they're getting side effects, they don't understand what tests they're having done. No one's sat down with them and really, given compassion, meaning I'm going to do everything I can to help you. And that's what I try to teach my medical students. I have medical students with me most days. It's like, not only do we understand your situation, we're going to do everything we can to help you. We're going to give you our contact, give you your glucose monitor, follow you, lower your medications actively. Okay, tomorrow we're going to communicate, via text or my chart. Let's see what your sugars are. Okay, hold that insulin today. It's a very active management, but they appreciate that.
Yeah, well, it's unique because, our approach is, we believe, providing them with the right tools, and it empowers them to make positive change, and sitting down beside them as a comrade to say, hey, look, here's an approach that can really give you some great results. And I think for diabetics in particular, the CGM just provides tremendous feedback. And we now get a reading off of their phone, or they can download the information to us, and we can see these fantastic trends. And basically you can look at a 30, 60, 90-day trend of the average at any
Yeah, and
particular time during the
it's
day.
great.
It's so cool. So we can see patients, well, you know, in the mornings, their sugars are high. You know, it's an enhanced on
Yeah, you
phenomenon
see
or
their
something.
daily graph and the trends, and yeah,
Yeah,
and
for a 30, 60, 90-day
yeah.
period, that just blows me away. Or then you can see, okay, there's, you know, in general, their sugars come down in the afternoon or the evening, and you know, then we can take some action based on that. So it's really good feedback, and everyone's running to me wanting to get a CGM, and that's fine. But it's interesting, Marc, because there's another subset of individuals, and in particular, they're women, and they seem to be metabolically healthy and not at their ideal body weight, and these are the ones that are more insulin sensitive. And I said, well, look, you can, you know, we don't see that they have much problem in blood sugar or A1C. And you know, I don't know that the CGM would
No, I
necessarily
don't
help
think
them.
it might just verify for them, as your lab testing will, that, you know, they're not diabetic. You know, they're insulin sensitive, but the same rules might apply, that they need to reduce the hyperinsulinemia, which might be the elephant in the room. But, you know, women store different than men. And, you know, is it subcutaneous? Is it the wiggly jiggly bits, which isn't going to cause them to die sooner? Or is it, you know, central visceral fat that we know is bad? So yeah, everyone's an individual. And but I think patients get, even they see their lines are flat, so if they want to, they're curious about it, they use it for 2 weeks, and it's like, okay, we don't get, it's, you don't need to keep doing this. And I don't want people to be so tied into their CGM to make them orthorexic, to be afraid to eat anything. And I think you're seeing some of that now too, where people who don't understand, okay, it's normal to have a little glucose spike after a meal, like that's not going to kill you, and they're afraid to, you know, have anything, you know, even the protein. So I think they need good coaching, like you're doing in your clinic, about, you know, what that data means for that person, and not set them down another path of disordered eating.
Exactly, Marc. Thanks for those comments. And we don't find that a high fat diet necessarily works for these insulin sensitive individuals.
No,
And
it's
so,
too many calories. I mean, they're going to, and some are fat addicted too. Joan Ifland will speak on that. But yeah, I mean, the high calorie, high fat foods are also very highly palatable, you know, so I see that sometimes too, if they're getting like online coaching, and someone, you know, a skinny low carber will say, well, I can eat all this fat I want, right? But if it's my obese low carber, the same rules don't apply, or they'll be on Pinterest looking at what someone's eating and loading it with more and more fat. But you know, that's why we're all N of 1 experiments. But yeah, be careful of that pathway too. I love eating bacon, but I'm not trying to lose weight. I could eat a pound and probably pound another pound. But if I'm trying to lose 50 pounds, it's probably not a good strategy for me to do that every day.
yeah, well, we're going to be addressing eating disorders at the conference next year. And, you know, we don't want to create more confusion or orthorexia, and people are just too focused in on things. And, you know, at the end of the day, we think what's important is to teach people about making the right food choices that control appetite. And at the end of the day, they feel good about their
Mm-hmm.
food choices, their health. I like to call it mindfulness. And on both sides of the insulin resistant and the insulin sensitive person, the mix of macronutrients might be different, or would be different for sure. But hopefully we find the right combination that will control appetite. So yeah, I guess maybe to get back a little bit to the zone 2 training, which will be your topic for the conference. Do you have any more thoughts about
Yeah, I
that?
can just define that for people. People don't like, what are these zones, you know, of training? They'll see, do I need heart rate monitors or, you know, fancy stuff? And you really don't. So what zone 2, so when we exercise, we're kind of like going through a series of gears, you know, so gear 1 or zone 1 is just like an easy stroll, right? You're just out walking on the boardwalk. You're not really stressing any system of your body, but it's good. It's good movement. Zone 2 is the area. So we have different muscle fiber types. We have these red fibers called slow twitch type 1 fibers. And these fibers love to burn fat for fuel. They're loaded with mitochondria. loaded with capillaries. That's why they're red fibers. And the fast twitch fibers, which can work a little bit on the aerobic side, but also anaerobic, these are more glucose-loving fibers, but they're for more intense exercise. So the zone 2 training is that level of effort where we're maximally taxing those slow twitch fibers. So it's what pace are you recruiting the most of those fibers without tapping into, without getting into gear 3, where you're starting to tap into the fast twitch fibers, because you need to go quicker. So if you need to get more power output, the fast twitch fibers, which use glucose, can produce more power quickly than the slow twitch fibers. Fat's a slower fuel to burn, but it can burn a very long time. So that training is you're maximally adapting that muscle fiber type. And what's important about that, even for high performers, is when people have trained those slow twitch fibers, maximally, that's when we're burning the most fat as we can as an individual. That allows us to do high intensity better, because when we do high intensity, we produce what's called lactate. Now, most people connotate lactate with acidosis and like, I have to stop exercising, right? Most people think, oh, I'm building up lactic acid, which isn't really what happens. But we produce, remember that pyruvate to acetyl-CoA pathway and the cytosol and all that. We'll maybe show a slide. So that's, the anaerobic side is the glucose gets broken down into pyruvate and you produce two acetyl-CoAs and you get the lactate. Now that lactate can have a couple different destinations. If you have this really robust type 1 fiber system, these slow twitch fibers, that lactate shuttles right back in to those muscle fibers to become aerobic. So we don't become acidotic. So you can work a little higher end if you've got this big engine. So every Tour de France cyclist has a massive zone 2 base, whether they're a low carber or a high carber, because they've just done tons and tons of riding at conversational pace, right? 80% of their training is they're just going up in the mountains with their team and their buddies, riding hours a day, and chatting about whatever they're chatting about. And then, they'll hammer the hills a little bit, but the base of their training is building up this big red muscle fiber base. And that's the foundation of health too, because that's mitochondrial health. It allows you to do more intense exercise and recover quicker, because if you're doing a CrossFit workout, it's not the intensity that gets you, it's being able to recover before the next set. You're going to go from station to station, you're going to do a Spartan race, you got to go climb something, really intense. But if you have a really good type 1 fiber base, zone 2 base, you can do that again and again and again and recover. But we'll explain it. But it's the good news is, if you're listening, this is not hard training. This is what you would do on like maybe a little higher intensity than a coffee ride, right? You're able to carry on a conversation as soon as your respiratory rate goes up, right? So we make CO2 when we're burning glucose, and the more glucose we're burning, the more CO2 we make, and we have to expel it. So as soon as you're exercising at an effort where you're having a conversation and then now you can't talk anymore, you're into gear 3 and gear 4. So most of us prefer to go exercise when we can talk to somebody or listen to a podcast or something, listen to music and be pretty comfortable. So that's the good news, is it doesn't need to be painful. You can do that, mix it up on your bike. Walking, power walking is great. So many of my patients have bad hip and knee arthritis. They can't run. Just get them to walk, walk with some sticks, the poles, if they're going to trail walk. It's really good for arthritis. Swim if you have access to a pool. Dance, cross-country ski, whatever it is you can do.
Yeah. Oh, great, Marc. Well, I also want to add, you're talking about endurance, but, resistance training, of course, is an anaerobic process, but that also develops mitochondria.
Heck yeah.
Builds mitochondria. It also adds to, shunting the glucose and energy into muscle. And so both zone 2 and resistance training together, really the point is that it is to perhaps enjoy exercise, to improve exercise and performance, but it's a longevity factor and it's a healthful factor. And so I in one of my talks, I've used the phrase that longevity is an endurance sport. And I kind of love.
Yeah, I would
love
agree.
that.
I mean, we're all kind of training for that age 90 so we can get up off the floor, maybe, so that's where strength training comes in and eating the protein. But yeah, everyone, like, my room here is set up for resistance training, so that's like the icing on the cake. Like if you ignore the resistance training, the bill will come due, right? Isn't that what they say? If you don't eat protein, the bill will come due. And it might be when you're 60 or 70, and your bone density is now weak because your muscle mass, and you fall and you break your hip. Yeah. So you got to respect the laws of strength and maintaining muscle mass, as well as mitochondrial function. And, metabolomics is all this mitochondrial stuff. Now it's another whole field, how the mitochondria function, or dysfunction, and the effect on human health.
Well, great, Marc. I'm really looking forward to you taking a deeper dive into Zone 2 training and giving us some more stories about the technical aspects. And you have a great way of really simplifying it in the end. So
I'll do my best in a half hour, but I look forward to coming out. It'll be great to see so many fun and interesting people like in the same room again. I learned so much from that environment, people asking just great questions. And, if you're listening to this and haven't been to one of these conferences, it's great. Like no matter what level you are, whether you're like a research scientist, they learn from talking to the real people doing this. And then the real people, they can pick up a lot of the science, because I think everyone really makes the effort to bring it down to like our level, Jeff, like family docs, right? They bring it to our level, which I think any citizen who's done some reading on their own like this, most people have a pretty good understanding of the things we're talking about, because of open access journals and podcasts now. So the education level of the average, citizen scientist now, is far superior, I hate to say it, than many doctors, where we learned something 30 years ago, and we haven't adapted at all. So I respect the citizen scientists out there as much as the people with the degrees.
Yeah, well,
I learn from them every day. My own patients, they did this and they had this response. It's like, well, let's look into that. That's cool.
Well, you already asked one of my last questions is what you enjoy most about coming to these events.
Yeah, the food's always good too. So like, I'm looking forward to the food.
Yeah.
And going to Denver. I spent 10 years in Colorado, so it's never a bad thing to go back to Colorado.
Yeah, but as you just described, the connection with people is fantastic, and the learning, sharing the science. So how can people find out more about you, Marc?
Yeah, I have a couple of places. I have a website, drmarksdesk.com. You can, if you want to contact me. I have a little running store here. So if you live anywhere near my area, so we're in Eastern West Virginia, it's Two Rivers Treads. We have a website, tworiverstreads.com. We do running clinics. We do running training, video analysis. So for people that are kind of geeky in the running space, come find us in our running store. It's a community store. We host races out of the store too, community running events, which are like walking events too. A lot of people find entry in and go walk these trails. We're in a national park setting here, so we're always doing trail runs and races.
Great, Marc. And
there's not altitude, so you can breathe better than doing, the Trans Rockies or something.
Well, I know when you come to Denver, you hit the trail. And
Breckenridge, the trails are wonderful. I have another town there up the passes.
You like to get your high altitude training when you come out.
Oh, heck yeah. Well, good. Well, it's been a pleasure. Look forward to February.
Yeah. And for our audience, if you want to hear more from Marc or our other speakers, please come to the conference in February. And for more information, you can visit lowcarbconferences.com. And until next time, and thanks again, Marc.
No, thank you. See you all in February.